long as this valve is wide open. And during systole, left ventricular systolic pressure is the same as the aortic systolic pressure. Again, as long as the aortic valve opens wide open. I'm going to give you a scenario. We have a 60-year-old gentleman. His name happens to be Rufus. And Rufus comes in because of progressive shortness of breath. So when Rufus exerts, when he walks on a block, he notices he's been getting short-winded. It resolves when he stops. He doesn't have any chest discomfort, mostly shortness of breath, which has become slowly progressive. Okay. Now, we do a cardiac catheterization, and we determine that the pressure within the left ventricle is equal to 160 over 10 millimeters of mercury. The pressure within the left atrium is about 10 millimeters of mercury. Okay. And the pressure within the aorta is 120 over 60 millimeters of mercury. What's causing Rufus's shortness of breath? Yes, Helen, go ahead. Go with it.
Well, there's the 160 and the 120 don't match, so that tells me something's wrong.
What does that tell you? Thank you. Praise the Lord. Say it.
Something's wrong with that aortic valve.
Thank you.
It's not open at the same time.
So the aortic valve is not opening fully. Because if it would open fully, these pressures would be the same. Instead, we have a 40 millimeter gradient, a pressure gradient. Pressure gradients are formed by stenoses or blockages. In fact, the greater the degree of blockage, the higher the pressure gradient. So to have a 40 millimeter pressure gradient means that the aortic valve, instead of opening, this is the aorta, instead of the valve opening like this, it's only opening like this, part way. And so this obstruction creates a pressure gradient across the valve. Okay? And so, particularly with exertion, okay, the left ventricle is having difficulty unloading. Okay? And so pressure in the left ventricle, because of that blockage, is going to build up. And that will begin to impact the diastolic pressure, which will affect the left atrium. And as left atrial pressure climbs, it's going to move retrograde into the pulmonary veins and into the pulmonary capillaries. And the pulmonary capillaries are going to begin to leak, extravasate blood. So the patient develops pulmonary edema. Did y'all follow that? Okay? Now, if somebody has aortic stenosis, where the aortic valve doesn't open, okay? Blood flow through that valve is not going to be laminar. It's not going to be smooth. It's going to become turbulent. Because when you have an obstruction, it makes blood flow become turbulent, which creates sounds. In this case, we call it sound of murmur. Is that murmur going to be, is it going to follow S1 or is it going to follow S2? The answer is that the aortic valve opens at the onset of S1. And so that murmur is going to be a systolic murmur. It's going to follow S1. So you can hear the first heart sound, boom, then you can hear a murmur, boom, boom, boom. You know, you hear a continuous sound between S1 and S2 as you get turbulent blood flow passing through that stenotic valve. Does that make sense? So when we listen for a murmur, timing is critical. we hear a murmur over the aortic interspace, which is the second right intercostal space. And that murmur follows S2. It's an aortic murmur, but it's not occurring during systole, it's occurring during diastole. Well, the aortic valve closes during diastole. And so if you have a murmur that follows S2, it means that the aortic valve is leaking, based on the timing. Yeah, we just went from zone 1, from kindergarten to 4th grade. Yeah, we're taking some foundational information and now beginning to apply it. Can you handle it? Did you follow? Carl, did you follow that? It's okay if you don't.
I think so.
Okay. It's something you have to think on. And we're going to cover this in more detail throughout the semester. Okay? But the idea is understanding intracardiac pressures is very, very important. All right. How are we doing time-wise? I think we're doing okay. This is one of these very super-duper technologically advanced classrooms. Watch this. One touch of the button. We changed the atmosphere. We changed the ambiance. All right. In the business we call this a chest X-ray. When we look at a chest X-ray, one of the things we assess is the size of the cardiac shadow. Here's the cardiac shadow. What a radiologist will do is measure the maximum diameter of the heart and compare it to the maximum diameter of the thorax. That ratio is called the CT ratio, which stands for the Cardiothoracic Ratio. A normal ratio is less than 0.5, or 50%. If that cardiothoracic ratio is greater than 0.5, then we say the patient has cardiomegaly. Cardiomegaly means a big heart. Has anyone ever said about any of you that you have a big heart? What they're saying is you have cardiomegaly. You have a disease. Yeah. Now, on physical exam, you can palpate the apical impulse. It's also called the PMI, or the point of maximal impulse. You can feel it, you can palpate it. It's at the fifth left intercostal space in the midclavicular line. It should fall about right here. If that PMI is displaced laterally or downward, it means that your heart's big. And it would correlate with a CT ratio of greater than 0.5. So let's look at part of this cardiac shadow. The right lateral border represents the right atrium. We can't really see the border of the right ventricle unless we took a lateral film, because the right ventricle is going to come right up against the sternum, but we don't have the right projection. Here, the left ventricle contributes to the apex of the heart. Okay. Now, there's a subtle change here along the left ventricle here. This little bump here is the left atrium. And then, here's the pulmonary trunk. It forms another little bump here. And this is called the aortic knob above. It's where the aortic arch transitions into the descending thoracic aorta. So some people call this the aortic knob, the pulmonic knob, which is the pulmonary trunk, left atrium, this is left ventricle, here's the apex. Here's the right diaphragm, left diaphragm. Some people call it the right left hemidiaphragms. Where it meets the chest wall, this is called the Costochronic Angle. And the costochronic angle should be sharp or acute like we see here. If someone develops an accumulation of fluid within the pleural space, within the pleural cavity, then it blunts this costochronic angle. It's no longer sharp. In fact, you can see fluid getting built up. Okay? You should know that the left and right pulmonary hilum, remember the hilum is the place where the blood vessels enter into the medial aspect of the lung. They should be kind of on the same horizontal line. Here's the left pulmonary hilum, here's the right. Vessels are going to then enter into the lung fields, and as the vessels move peripherally, they become progressively more attenuated. It means their markings become more spaced out, weakened. So that's the normal progression from hilum to periphery, is the vessels become more splayed and weakened in appearance. Remember that the right lung has an upper lobe, a middle lobe, and we're catching part of the lower lobe, which extends toward the posterior aspect. The left lung only has an upper and a lower lobe. If you can see, sometimes you can make out the horizontal fissure or the oblique fissure. On the left side, you only have an oblique fissure. Here, this column of air is the trachea. Where it bifurcates is the carina, right and left main stem bronchi, or sometimes you call them primary bronchi. Here's your gastric air bubble, this radiolucency here. If something appears dark, like the lung fields, we say they're radiolucent. If something appears white, we call it radiopaque. So because the heart is made up of muscle and it's filled with blood, it blocks the X-ray beam. It appears radiopaque. Whereas because the lungs are filled with air, they look more radiolucent or dark. When you perform an X-ray or evaluate an X-ray, you also look at the bony features. Left and right clavicles. Normally you want to see that the clavicular heads are equidistant from the midline. See the spine's processes, they should be equidistant. If they're not, it's because the person is kind of standing at an oblique angle like this. So it's not good technique. You should be able to just make out the vertebral bodies through the heart shadow, which you can. Okay? So this is really good technique here for this chest X-ray. This is simply an electrode here. Here's an electrode right here. You see the scapula, the humerus. It's all here. You know, there was a TV show called Scrubs. You remember that, Scrubs? And in the opening scene, they always showed a chest X-ray, and it would always bother my wife and I because the chest X-ray was reversed. They had the apex pointed to this side. It was like, it took till season 3 before they corrected that. It's funny, when you're in the medical field and they do something wrong on one of these medical shows, you always recognize it right away. What's the problem here?
Cardiomegaly.
Cardiomegaly, yes. This person's got a big heart, like Holly. Right? It's too big. The cardiothoracic ratio is greater than 0.5. Here's the aortic knob. You can see where the aortic arch is making a turn. Okay. Here's the pulmonic knob. Okay. You can kind of just make out the left atrium here. Here's the left ventricle. This is the right atrium, but it's big. If you look closely, there's a horizontal fissure here. Okay. Now, this is not just cardiomegaly, but what you see is increased markings. What's happening? The pulmonary vessels are extravasating fluid. You're developing edema. So you see here a bilateral pattern of increased fluffiness as fluid extravasates from the pulmonary vessels into the lungs. So this person has some congestive heart failure. With a big old heart and blood extravasating, not blood, but fluid extravasating into the lungs. They're hurt for certain. This person, I guarantee you, was short of breath. okay? They are in trouble with a capital T that rhymes with P. I'm in trouble. That comes from the music man. Yeah, right. That was a good movie. Favorite movie of all time, by the way?
His favorite movie. Oh,
Yeah.
yours, what is yours?
I'll tell you what it Sound of Music.
I like that movie.
I like the historical perspective, you know, with the Nazis and all that. And I thought it was a well done movie. Second, Juno. I thought Juno was good. You guys.
Juno?
Kayla, what's your favorite movie?
Yeah, Juno.
Juno? Who said Juno?
No, she asked what you was talking about.
I didn't know what you said.
Juno.
Juno.
Yeah. Did you ever see that?
Nope.
Write it down. Ray, what's your favorite movie?
Bad Boys 2.
Write it down. Give us a book report on Bad Boys 2. All right. All right, this again is one of my wife's slides. Cardiomegaly is enlargement of the heart. A cardiomyopathy is a disease resulting from decreased function of the myocardium. It's really a disease of the myocardium, okay? And most often it leads to not only cardiomegaly, but what's called a cardiomyopathy, but a weak heart. So it leads to congestive heart failure. Congestive heart failure is a situation where the heart's unable to pump effectively. So what happens is blood or fluid backs up and the patient develops pulmonary edema. Sometimes they'll develop, with congestive heart failure, you can develop a pleural effusion as well. Now, pericardial effusion is an accumulation of fluid in the pericardial space. That fluid can be simply serum, can be water, can be blood, as we talked about with tamponade. We talked about if there's enough of a pericardial effusion, like we talked about with a tamponade, the fluid can compress the heart, so it's unable to pump effectively. We talked about valvular stenosis, where the valve opening is not normal, it's decreased, blocking flow. We talked about valvular regurgitation, where a valve leaks. So those are the two primary valve problems that involve the heart. Either a valve doesn't open fully, we say it's stenotic, or it leaks when it closes, and it's regurgitant or leaky. And the last thing we're going to mention here, fetal circulation. We talked about the fact that in fetal life there's an opening between the right atrium and the left atrium. Why is that? Why the heck would you want an opening? Well, when you're a fetus, and we've all been there, when you're a fetus, your lungs are not working. You're in utero. You're not exposed to air. So your lungs are just taking up space. And so the fetus is getting their oxygen from maternal blood. That maternal blood is flowing up the inferior vena cava into the right atrium. Now, ordinarily that blood would flow into the right ventricle and into the lungs, but that's inefficient when the lungs aren't working. So the foraminal valley allows some of that blood, that oxygenated blood, to be shunted directly into the left atrium, so that then it can be pumped into the systemic circuit, bypassing the lungs. It's a shunt. Okay? Now, there's a second shunt that occurs in utero. And it's an opening, it's a shunt between the pulmonary trunk here and the aortic arch. Right there. It's called the ductus arteriosus. Again, it serves the same purpose. For any blood that reaches then the pulmonary trunk, much of it gets shunted into the systemic circuit, bypassing the lungs. Now, we said that when the foraminal valley closes, it becomes the fossa ovalis. When the ductus arteriosus closes, it scars down, forming a ligament called the ligamentum arteriosum, right here. Ligamentum ligamentum arteriosum. So if we go back in time, let's just go all the way back. Good times. Remember this? Hit the lights. Action. Ligamentum arteriosum. So typically what happens is just like the fossa, the foramen closes around the time of birth, so does the ductus arteriosus. All right, so that blood can no longer be shunted into the systemic circuit. Wow. So we covered, we covered this whole problem. This was all stuff that hopefully you remember from A&P2. But I thought it was important to go back and to go through this again. Was that helpful? Is it all coming back now? Okay, like that first date. You remember that first date? Nobody? Do y'all remember your first date in school? I have a son. Okay, this is crazy. He went to Jesuit, and as a freshman or sophomore, I forget what it was, he went to a dance. I remember it was a kind of good thing. He was a little nervous about the whole thing. And so he dated a girl from North Shore. Okay, from the and so he didn't actually, no, I'm taking it back. He didn't actually, he went with somebody else, but someone else went with this girl from North Shore, and they were just sitting at a table, and because it was his friend who was dating this girl named Tasha.